Regarding renal replacement therapy, we will see how to write a short note for an MD medicine resident because this has been asked in a recent theory question. So we will see this in a short and how this can be answered. RRT or renal replacement therapy. Under what headings we are going to see? We are going to see first what is RRT. What are the indications of RRT in AKI? Indications in CKD. Types of RRT with respect to the each type under the subheadings, like if we take hemodialysis, types, apparatus, what is the mechanism, advantage and disadvantage in short, and finally one conclusion. Why you should be aware of this theory question even the theory exam is over? This you might get in the grand viva. Probably the question the examiner might want, the examiner, if he wants to know from you directly what is RRT rather than correcting your paper, they might ask you. Like you will go to the first one. What is it? RRT are also called as kidney replacement therapy. It is nothing but replacing the functions of the kidney. In technical terms, if you have to put, it is the group of treatment modalities used to replace the kidney function when either in acute kidney failure or in chronic kidney failure as required. So what is RRT? RRT or KRT? These are the group of treatment modalities used to replace the kidney function in acute or chronic settings of renal failure as required. So this is the proper definition for RRT. Then coming to the indications. Kidney can fail under two conditions in acute situation which is called AKI or in the chronic form which is called the CKD which is usually more than 3 months and the eGFR as it falls towards less than 15. As a final year MD, you should know the indications of CKD and AKI. Some parameters are common, but few differences there, subtle difference. First, we will see the indication in CKD patient. So I usually classify this as lab criteria and the clinical criteria. This was the slide taken from the old video only. So if we take the lab criteria, hyperkalemia, resistant hyperkalemia, that is potassium more than 6, acidosis, which is refractory to treatment, usually CKD patient won't respond much to medication. So what is the pH level? pH less than 7.1 forms an absolute indication. Bicarbonate less than 5 forms an absolute indication. pH 7.1 to 7.2 relative indication. Similarly, bicarbonate 5 to 10, some textbook 5 to 15. Refractory hyperphosphatemia also. Suppose if it is not getting controlled with the phosphate binders, S in CKD patient, hyperphosphatemia also forms one of the indication. And what is the urea create cutoff? There is no specific urea create cutoff. If we take eGFR less than 15, is it absolute indication? No, you have to consider for renal replacement therapy. So you have to prepare for fistula, you have to advise the patient regarding the transplant. There are trials which has been done between initiation of dialysis between lower eGFR, that is 8 to 10, and the higher GFR. There is no gross difference. This kind of trial question might not be required for the MD resident. I'm just giving for your info. eGFR less than 15, you have to prepare the patient for RRT, not start the RRT if it is not required. Urea more than 180, creatinine more than the range of 6 to 8, there is a chance patient will develop all these uremic feature starting from head to foot, uremic pericarditis, uremic encephalopathy, volume overload, gastritis, coagulopathy, uremic lung, chronic malnutrition. See, even though volume overload is not uremic manifestation, it is water accumulation. So rest 1, 2, 3, 4, these uremic things. In CKD, what is the difference with respect to AKI and CKD? Chronic malnutrition forms an indication and hyperphosphatemia forms an indication in CKD. This is with respect to the CKD. So let's see what is the difference between initiation of dialysis in AKI and CKD. CKD we have seen in detail. There are many features which fall in common in AKI also, but in In AKI, anuria also forms an important indication of dialysis because if a patient is anuric for 24 hours despite giving adequate fluid, we can't wait for the lab value to get deranged to start the dialysis. So, AKI anuria is also one of the subtle indication that you have to be very quick enough to pick it so that before the derangement you have to give dialysis to stabilize the patient volumically also. So in CKD, chronic malnutrition, hyperphosphatemia, these forms an indication. That is the subtle difference between AKI and CKD. Till here, I hope you are clear. When to initiate RRT in AKI, when to initiate RRT in CKD. Yes, we have seen. Now go to the next heading. What are the types of RRT? So how you can give RRT? There are three modalities of RRT. First is the hemodialysis, second is the peritoneal dialysis, third is the transplant. So in the types of RRT, you have to write 1 hemodialysis, 2 peritoneal dialysis, 3 transplant. So coming to the first one, hemodialysis. In the theory part, you have to write under the following subheading with respect to the hemodialysis. What are the types of hemodialysis? What is hemodialysis? Hemo is blood. Dialysis is the process of purification. So hemodialysis, blood is being involved directly in this process. There are subtypes. If we give weekly thrice, weekly twice, intermittently, that is called intermittent hemodialysis. If we give continuously for 24 hours, that is called as CRRT, continuous renal replacement therapy. I am not giving it continuously, I am not giving it intermittently, but I am giving for 8 hours for a long period because here ideally 4 hours, 2 to 4 hours intermittent hemodialysis. If I give for 6 hours, 8 hours, that is called slow low efficacy dialysis or PIRRT, prolonged intermittent renal replacement therapy. Some books they can say as hybrid therapy, hybrid model. Since I'm not giving for a 24 hours duration, I'm not giving it for a short duration. I'm giving it for a hybrid, like somewhat 6 to 8 hours. This is called hybrid therapy. Some books now started using the terminology expanded dialysis. So as of now, at least you should be very clear. The types include intermittent hemodialysis, CRRT, SLED or PIRT, and expanded hemodialysis where some other mechanism of increased clearance is also there, extended duration of dialysis. So this is what regarding the types. So you can remove this at least for the final year level. These three you have to be aware. What is the advantage? There is a huge hemodynamic fluctuation in IHD. In CRRT, that won't happen. In PIRT, SLED, the chances is less. Suppose if I am using only it for volume stabilization, that is called as SCUF, slow continuous ultrafiltrate removal. So these are all the 4 subtypes. If you have enough time and the page to write it down, in the answer sheet you can write, otherwise this is the gross outline. What are the types of this hemodialysis? Then coming to the mechanism, what is the major mechanism involved? One is diffusion, another one is convection. This is the two major mechanism involved. And what are all the upgraded form of this hemodialysis? Hemodiafiltration is there. Probably these hemodiafiltration probably in the theory exam probably they might not expect you in an entrance. Probably few question might come, but theory you can skip this hemodiafiltration and all. So what is the mechanism? Diffusion and convection. So we'll go to the next subheading. What are all the things which are involved in the hemodialysis apparatus? It can be divided into dialyzer, 4 component dialyzer, or also called as hollow fiber artificial kidney. This you might get in the spotter. First one. Second one, blood circuit, which is nothing but the circuit involved in taking the blood from the patient to the dialyzer. Third one is the dialysate circuit. And the last fourth component is the hemodialysis machine. These are all the four important components which is involved in the hemodialysis apparatus 3 and 4. Which is the most important one is the dialyzer or the hollow fiber artificial kidney, under which clearance occur. Regarding the membrane and all, they might not ask. So if you have interest, you can go through the hemodialysis and the Harrison chapter in the dialysis. Regarding few sentences regarding dialyzer and blood circuit, dialysate circuit are being given. So coming to the advantage and disadvantage. Advantage, hemodialysis can be given in both AKA and CKD setting. Even in a hemodynamically unstable patient, the modification can be done. It is very effective in hyperkalemic patient. And what are the other advantage? Whatever the disadvantages of the peritoneal dialysis are all advantages of the hemodialysis. In an acute setting, it can be very well started. Compared to the financial burden, compared to the transplant, the burden is less. These are all some of the advantages. Electrolyte stability will be very rapid. Prescription can be adjusted as per the requirement. What are the disadvantages? Vascular access is required. You have to put a catheter. The catheter might get infected. CRBSI. The catheter might get blocked. Yes, even though hemodynamic stability is there, patient might go for sudden cardiopulmonary arrest during the dialysis. Most problem occur due with the vascular access. Fistula failure can occur. And with respect to this hemodialysis, one important point, the vascular access which comes in the blood circuit. AV fistula is called as the lifeline of CKD patient. This you have to tell. What is AV fistula? It is the arteriovenous connection in the non-dominant hand, especially between radiocephalic fistula, which is used in a CKD patient. In AKA patient, fistula is not required. And a few points, if any student interested to write regarding vascular access can be temporary or permanent. Permanent in the sense it works for a longer duration than the temporary. In that AV fistula, AV graft, tunneled catheter comes. Tunneled catheter, tunneled cuffed catheter. In the temporary, lines femoral, internal jugular, or subclavian vein direct catheters, dialysis catheters are there, which is called the lifeline. AV fistula is called the lifeline of CKD patient. So whenever a dialysis is required for more than 7 days, the recommendation says to use the tunneled catheter rather than this one. What is the ideal duration? Femoral catheter have to be ideally removed before 72 hours. IJV 4 to 6 weeks. Subclavian better not to prefer. If so, better 4 to 6 weeks you remove it. So that's all regarding hemodialysis. This is what you can write in a theory paper. Coming to the next one. Next form of RRT, peritoneal dialysis. Here also types, mechanism and apparatus. Types, continuous ambulatory peritoneal dialysis and automated peritoneal dialysis. And these are all the things for CKD. In acute PD, if you are using PD in a AKI, this is called as acute PD. Why it is called ambulatory peritoneal dialysis? Because after filling the fluid in the abdomen, patient can move around. Why it is called continuous? It is continuously the mechanism is occurring. A means automated peritoneal dialysis. There is a machine which pumps the fluid into the patient abdomen and drains it automatically. No need for the gravity. That is called automated peritoneal dialysis. What is the mechanism? Mechanism is same, diffusion and convection. Is there any apparatus similar to hemodialysis machine? If there is a patient, PD catheter have to be inserted and left in situ. Peritoneal dialysis bag which contain peritoneal dialysis fluid, probably which contain dextrose and electrolyte. This will be put into the patient abdomen. For example, at 8 a.m. it is being put Within 15 minutes, entire 2 liter has been put inside the abdomen and this bag will be detached. This patient can go to office, do his work. Meanwhile, the process of diffusion will occur. Why? There is an osmotic agent which is dextrose, which start pulling the fluid, and the electrolytes are kept in a way equilibrium occurs. The waste product will come this side to the fluid. Around 3 or 4 hours afterwards, the patient drains the PD fluid using the gravity and it will drain out. You can discard it. So this is what simply peritoneal dialysis is. So what are the apparatus? PD catheter, PD fluid, and if it is a gravity related peritoneal drainage, any no machine is required. If machine is being used, that is called automated peritoneal dialysis. And yes, peritoneal dialysis can be used in both AKI and CKD. Both it can be used. So PD fluid composition, they might not ask you. The osmotic agent which is used is the dextrose, as we are using dextrose. Ecodextrine are the two osmotic agent using in the PD fluid. Then coming to the advantage and disadvantage. What is the advantage of PD fluid? First, blood is not involved. Second, the patient can be mobile. He can go to office. No need for him to come to the hospital or in center. No blood involved. And it is somewhat easier if the patient is being trained. If he knows he can do it properly, clearance will be achieved gradually. And what and that is also advantage. No gross hemodynamic fluctuation. What is the disadvantage? PD catheter insertion might be painful. PD catheter might get infected. PD peritonitis can occur. The training takes lot of time. Even in the OPD, counseling takes lot of time. Leave out the training. Training takes more time. So in a illiterate kind of population, it will be very difficult to do the training. Initial part में trainer might be required, and the disadvantage is costly. Per session, if you take probably per day approximately 1,800 to 3 to 4,000 might be required, including the PD catheter and all. These are some of the disadvantages. So whatever the advantages of hemodialysis, probably you can put and correlate vice versa. Advantage of PD, disadvantage of PD, compare it with hemodialysis and use it vice versa. I hope this much information is enough for a MD medicine resident, and probably they might be asking regarding PD. What is acute PD? If you start an AK patient, there is acute PD. So one more point, if examiner is so uh, interested and so and student is able to answer at least almost all the points discussed over here, they will ask clearance. How to calculate the clearance? Just to say there is some terminology called KT by V, which is being used in hemodialysis also, peritoneal dialysis also, or urea reduction ratio. Nowadays we are not using this urea reduction ratio, we are using KT by V. What is URR? Urea reduction ratio is nothing but pre-dialysis urea minus post-dialysis urea divided by pre-dialysis urea. This is called urea reduction ratio. Nowadays this is being replaced by KT by V. This is some formula based on the clearance, time and the value, which might be required for your entrance preparation, not for your theory. So if they ask, just say KT by V, at least examiner knows you have studied and you have forgot. KT by V itself is a separate topic. We will discuss it in some other video. Third one, transplant. Students का question आता है सर transplant is a RRT? Yes, transplant is also a form of RRT in CKD patient because it is replacing the kidney function. So if we put it in the technical term, is considered the most effective because hemodialysis and peritoneal dialysis won't replace the endocrine function. It will replace the homeostasis function. It will replace the excretory, somewhat clearance function, but it won't replace the endocrine function. So kidney transplant is the considered the most effective form of RRT because it replaces both endocrine, excretory, and homeostasis. सब कुछ it handles. So better quality of life will be there, more physiological way of replacing the kidney function. So where the new kidney will be kept? Will the old kidney be removed? No, old kidney won't be removed. New kidney will be kept in the iliac fossa, preferably right iliac fossa. If the vessels are good, considering the technicality from the donor, it will be kept in the right iliac fossa. Is blood group same blood group is mandatory? Blood group can be different. That is called ABO incompatible transplant. If it is same, that is called ABO compatible transplant. So this much information in points, if you write, probably in 1 to 2 pages you can complete. I have bit elaborated so that it will be helpful for you in Viva to answer. So in conclusion, if we see the summary for renal replacement therapy, what to write? RRT or the kidney replacement therapy. It is a form or group of modality of treatment used to replace the kidney function. So then you are going to write the indications of RRT in AKI and CKD. One difference is in AKI, anuria is also one of the indication. In CKD, hyperphosphatemia, chronic malnutrition forms one of the indication. Then coming to the types. What are the types we have seen? 3 types: HD, PD and transplant. And regarding the HD, what are the things we have seen? Types, mechanism, apparatus, advantage and disadvantage. Then coming to the PD, what are the things we have seen? Types, advantage, disadvantage, mechanism and the apparatus. Then transplant. What is the advantage of transplant? It replaces the endocrine function also. Erythropoietin भी secrete हो जाता है kidney, new kidney से, and it is the most physiological way. And this concludes. Conclusion में what you will write? Renal replacement therapy can be required in AK or CKD, and there are trials to compare when to start, when to stop and all. That level of discussion might not be required for the MD medicine resident. Just say the indication. And if examiner is interested, they might ask in AK when we will stop the dialysis. If the urine output is adequate, if the patient hemodynamically stable, and if you know the etiology and if the urine output has also started improving, that is the time where you will start the dialysis, stop the dialysis. What is the urea creatinine cutoff? There is no particular cutoff. As the urine output started increasing, the urea creatinine will start coming down. That is where you will stop. So this much information might be required from a MD medicine theory exam goer. You are ready for the practical. Sara, बता देना. Bye bye.